Hello everyone, welcome back to today's class. We are going to discuss few stuff today. So let's start pushing endocrinology. Let's take a look. So as you can see, we are almost done with endocrinology. Today we are going to discuss the pathology of the pancreas. We are going to speak about diabetes mellitus. Guys, in the USMLE, basically they like the diseases that are really common. For example, hypertension, myocardial infarction, diabetes mellitus. So what I'm trying to say that you are more likely to get a question on diabetes mellitus than getting a question about pheochromocytoma, for example. Why? Because basically it's just like more common. Okay? So let's take a look. Diabetes mellitus. The symptoms is polydipsia, polyuria, polyphagia, and weight loss. Basically, the patient is always thirsty, always wanna. Yes. So the patient is always thirsty, always going to the urine, going to urinate and eat so much. Why? Because they are extremely hungry, because they are losing a lot of glucose. Also, weight loss can occur. So we have diabetes mellitus type 1 and type 2. In the type 1, you can have ketoacidosis. Can we have ketoacidosis in type 2? Diabetic ketoacidosis, can we have it in type 2, do you think? Well, I hope you are thinking that it's not. It's not a thing. It will not happen in type 2. So it does happen in type 1, but it does not happen in type 2. If you see a case of DKA, this is automatically type 1. Okay? It's type 1 automatically. So hyperosmolar hyperglycemic state is the thing that can occur in type 2 diabetes mellitus. We will speak about each of these cases. Rarely, it can be caused by an unopposed secretion of a growth hormone or epinephrine, which is sometimes like, yes, it's diabetes, but it's kind of like not the common etiology. So it can be because of so much growth hormone or so much epinephrine or so much steroid. Why? Because all of these processes increase a process called gluconeogenesis and the glycogenolysis. Can you tell me what does the gluconeogenesis and the glycogenolysis have in common? What both of them increase? Absolutely, yes, glucose, yeah, sugar. So also seen in patient on steroid therapy, like, yeah, steroid diabetes, basically patient who are chronically on steroids for some causes, for example, immunosuppressant state. You want to make them immunosuppressant. For example, they are a transplant patient. In that case, giving chronically the steroid can lead to diabetes mellitus. Okay, let's speak about chronic complication of diabetes. To make it simple for you, before we read about this, I want you to know, well, two things. First one, the problems in the patient are subdivided into microangiopathy and macroangiopathy. That's the main classification. So they can be either microangiopathy or macroangiopathy. The other classification can be the problem is caused by non-enzymatic glycation and osmotic damage. So this is another way of and another classification that can occur. So let's take a look here. We have chronic complication include the following. Non-enzymatic glycation. For example, do you remember which portion of the kidney was the first to be having like problem because of the diabetes? Which portion of the kidney was the first to have the problems? Not BCT, no. Nope. The efferent arteriole, absolutely correct. The efferent arteriole was the first to have a problem. And which problem he had? He had non-enzymatic glycation, which led to decrease in the diameter of the efferent arteriole. So what is going to happen to the GFR? Initially, it's going to increase, absolutely correct. So the GFR initially is going to increase. But after sometimes the sclerosing and the hyalination is going to continue all over the kidney. So after sometimes what is going to happen to the GFR? It's going to go down. It's going to go so down, it's going to lead to basically chronic kidney disease. Okay, chronic kidney disease. Okay, so you can see how serious it is. How can we prevent it? How can we prevent chronic kidney disease in case of diabetes? Which medication can we give to prevent this chronic kidney disease? Which medication? What do you think? Nice. Okay, ACE inhibitor. Why? Because ACE inhibitor are going to decrease the angiotensin 2. Angiotensin 2 normally lead to vasoconstriction. So if we inhibit angiotensin 2, the efferent arteriole is going to be vasodilated. And when it is vasodilated like this, what is going to happen to the GFR? Absolutely correct. So normally the GFR is here. It's going to decrease, but not by much. It's going to decrease a little bit. And this is going to be persistent. As you can see, the GFR is decreasing, but it's not decreasing so bad. So the patient is not in chronic kidney disease. It just decreased mildly, so you will not have in the future the hyalinosis of the glomeruli. Okay? Good. So they write small vessel disease and the large vessel atherosclerosis. So microangiopathy, macroangiopathy. Microangiopathy, diffuse thickening of the basement membrane can occur. So, well, why this is even problematic? Well, it can lead to multiple problems, starting with retinopathy. They like you to know exactly what you are going to see in the eye. Basically, because of the infiltration of the basement membrane, you are going to have damage of the basement membrane, which can precipitate to formation of aneurysms, which is an outpouch of the vessel, inside of the arteries of the eye. Okay, so this is microangiopathy. So when you take a look at the eye, diabetic mellitus retinopathy. So if you take a look at these patients, they are going to have just a second. I hope you can see the aneurysm here. There is an aneurysm. And hopefully I will find, yeah, this is much better. Okay, you can see pouches of hemorrhage, like there is some hemorrhage here, 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 and here. And there is this whitish spots here. Yeah, this is basically the cotton leaf spots. So yeah, you can see here, by the way, there is two pathologies of the retina caused by the diabetes, but in general, for now at least, just think about the hemorrhage and the aneurysm. That's it. Okay. Okay, so they're right. Hemorrhage, exudate, which was the whitish stuff there, microaneurysm, and vessel proliferation. Oh, well, vessel proliferation, this is going to be serious. Well, yeah, how serious? Well, it can lead to blindness of the patient. Okay, can we inhibit the vessel from proliferating? Is it even possible to inhibit a vessel from proliferating in the eye? The answer is absolutely yes. It's possible to inhibit the proliferation of the vessel in the eyes by giving one medication. Any idea what is the name of this medication? Yes, it's a monoclonal antibody against the VEGF, which is basically basilizumab. It's called basilizumab. So the basilizumab is a monoclonal antibody against the VEGF, which normally lead to proliferation of the vessels. So in case of its absence, there will be no, in case of a monoclonal antibody against the VEGF, that means the patient will not have any more proliferation of the vessels. That will lead to killing of the vessels. In the old book, they used to mention it here. They don't mention it anymore. I don't know why. I think they must have move it somewhere else. Okay, so let's keep going. They write also about glaucoma. So yeah, the glaucoma can occur. Basically, the patient will have less outflow from the eye, which is going to increase the intraocular pressure. Nephropathy as well, we discussed this one. Firstly, the efferent arteriole is affected. Then the whole kidney is affected by a sclerosing process. So nodular glomerulosclerosis. Guys, this is a nephritic or a nephrotic syndrome? It's a nephrotic syndrome, absolutely. So that can lead to a progressive proteinuria, initially microalbuminuria, and the ACE and the ARBs inhibitor are protective. And we said why they are protective. Because we said that they dilate the efferent arteriole, reducing the chance of increased hydrostatic pressure inside of the glomerular capillary, which decreases the chance of glomerulosclerosis. Arteriolosclerosis caused by hypertension can also lead to chronic kidney disease. Okay, so the next thing what I want you to know that we have, was the microangiopathy. Now it's the macro, big vessels. Macroangiopathy include atherosclerosis. Why? Well, basically the glucose molecules are going to hit the endothelial cells and lead to their damage, okay? So this is a glucose molecule and it can hit the endothelial cells and basically injure it, leading to endothelial injury, which can promote to damage. Also, coronary artery disease can occur in this patient, and the peripheral vascular occlusive diseases, which means that it can be other organs that can have the occlusion, including the femoral artery, for example. It can be even the renal artery, for example. Okay, so it also can lead to gangrene and limb loss. And by the way, I don't know if you ever saw a diabetic foot in real life, but I have one question. Is it painful or painless in the patient with diabetic foot? Okay, something like this. Is it painful or painless? Or this? It's totally 100% painless. Why? Because they have a neuropathy. They cannot feel their limbs, so they are not going to feel a pain. Actually, let me give you a trick for the USMLE. So the trick says something like this. Let me just make it to you. So if we say that this is a foot of a human being, okay? So this is the foot. Okay. If you have a lesion that is located at the plantar surface, which is the down surface, this is the ground. So the down surface, the plantar surface of the leg, okay? This is diabetes mellitus. If the lesion is located at the tip of the finger, the tip of the toes, basically, this is what? What do you think? Tip of the toes. Tip of the toes, it's going to be, come on, any idea? If it's going to be in the tip of the toes, it's going to be, okay, good. So it's going to be arterial insufficiency. Arterial insufficiency. Arterial insufficiency affects the tip of the toes. Okay, what about if it was at the malleus, medialis or lateralis? Mostly malleus medialis, actually. So if it's at the malleus, which is third position, this is going to be due to venous insufficiency. So please make a note about this. If it's at the tip of the finger, this is arterial insufficiency. On the plantar surface, diabetes mellitus. At the malleus, this is what? This is venous insufficiency. So now we can take a look at the diabetic foot, and it will make much more sense after that statement. Now you can take a look at the diabetic foot. Notice plantar surface, right? So this is what? This is going to be diabetes. If we take a look about arterial insufficiency, in cases of arterial insufficiency, I want you to know that Oh, look at this guy. The tips of the finger. See? The tips of the finger. Venous insufficiency. So venous insufficiency are going to be at the malleus. Malleus. Yeah? So the lesion is going to be mostly at the malleus. Good. So we have three diseases. I hope you mastered them. Now we can move on. So to move on, we are going to speak about, gangrene can leading to limb loss, cerebrovascular disease, which is basically strokes, and MI is the most common cause of death in patients with diabetes mellitus. Osmotic damage. Osmotic damage can be happening due to sorbitol accumulation into organ with aldolase reductase, but they have a decrease or absence of the sorbitol dehydrogenase. These organs include the following. Schwann cells. Can somebody tell me where is the Schwann cells located? No, Schwann cells are not in the brain. Brain have oligodendrocyte. Schwann cells is the myelin producing cells, which are located on the peripheral neurons. So the CNS, this is important. CNS have oligodendrocyte, okay? Oligodendrocyte. While the BNS, peripheral nervous system, is going to have Schwann cells, okay? Oligodendrocyte, that's CNS. Schwann cells, that's BNS. Good. So the Schwann cells are going to have no sorbitol dehydrogenase, which means plenty of sorbitol is going to accumulate inside of the Schwann cells. This sorbitol is osmotically active, which means it's going to suck what? Water. Yep. Sucking more water lead to the cell to become enlarged, and then it bursts, which makes it basically dysfunctional. That's why the patient have the neuropathy. So yeah, another organs that does not have sorbitol dehydrogenase is the lens, which makes sorbitol accumulate inside of the lens, which lead basically to something called cataract. Yeah. So neuropathy is a motor. It could be motor or sensory. Glove and stocking distribution. What is that? Well, basically, if I draw a human being, this is the gloves, and this is the stocking. Okay, so the hands and the foot. So gloves and stocking distribution of sensory neuropathy and autonomic degeneration. So that can promote GERD, gastroparesis, and diabetic diarrhea. Now I have a question, guys. Can somebody tell me, how can we treat gastroparesis? I told you about two drugs that can be used to treat gastroparesis. We spoke about them in the section of GI. Excellent job. Erythromycin. Why? Yep, you are correct. So the erythromycin can bind to the motulin receptor, the M receptor. So when the erythromycin, an antibiotic, binds to the M receptor, that can lead to motility. Also, don't forget about metallochlorbromide. Metallochlorbromide, it's an antiemetic, which means it prevents vomiting, but also it can lead to GI motility and activation of the peristalsis. Okay? So, okay, gastroparesis and diabetic diarrhea. Nice. So far, so good. We are done with the neuropathy. So the next one is going to be cataract. What is cataract? Well, it's just an accumulation. It's just an accumulation inside of the eye. Let's take a look at that. Inside of the lens, to be more exact. So this is the lens, of course. And the accumulation of which substance inside of the lens is going to lead to that? Can you tell me which substance? Come on, which substance in diabetes? Sorbitol, absolutely correct. Yes, it's sorbitol. Sorbitol is going to accumulate and lead to this. Nice. So can you see the white inside of her eye? Yep. Also, people who work in the sun have more chance of getting cataract as well. Okay. So how to treat cataract? Simply, you remove the lens and put a new lens. Okay, so let's speak about the diagnosis. Well, if I go eat a big cake, I'm totally healthy human being. If I eat a big cake and I drink a lot of Coca-Cola and then come back to you. And you check me for like my blood sugar. It's going to be high, really, really high. Does that mean I have diabetes? Not really. It's all okay. Not really. So, okay, so I'm fasting and then I come to you and my blood sugar is 70, which is normal. And then you feed me a biscuit and so you feed me a lot of sugar and now it's 200. And then after 1 hour it goes back to normal. Do I have diabetes? No, not really. It was corrected quickly. Okay, so to make a diagnosis of diabetes, yeah, good tolerance. If to make a diagnosis of diabetes, there is multiple ways. One of them is this one, which is glycolated hemoglobin. Guys, what is the um, average age of an RBC? How long can the RBC live? Well, the RBC can live between 90 until 120 days. Okay, so this is like 3 to 4 months, correct? Okay, what does the RBC has inside of it? Hemoglobin, and that hemoglobin can be glycated, which means glucose can stuck into it. So this is basically what this is hemoglobin A1C means. It's a glycated hemoglobin, which means it's how much sugar was stuck into your RBCs for the previous 3 to 4 months. So if I'm a tricky diabetic patient and I keep eating sugars, but I know that I have an appointment with you, the doctor, next week. Yes. So I just decrease I eat nothing for 2 days before my appointment with you, and I come to you, and I'm having a smile on my face. You check my blood sugar, and it's okay, it's normal. But then you do the glycolated hemoglobin. Will it be high or normal? It will be high, absolutely. So yeah, if you have a glycolated hemoglobin more than 6.5, this is diagnostic of diabetes mellitus. Reflect average blood glucose over a prior 3 months, influenced by an RBC turnover. Basically, this is how long the RBC can live, 3 to 4 months, and it's just telling you that okay, this patient basically can 3 4 months. This is how long these RBCs were exposed to the sugar and how much are they glycated. Fasting plasma glucose. So the fasting plasma glucose goes something like this. So the fasting plasma glucose, if it was more than 126, you start to become suspicious. Okay. Of course, the definition of fasting, it's when you don't eat anything more than 8 hours. So mostly we do it for the patient early in the morning. Okay. So 2 hours oral glucose tolerance test. So it's patient that has not like you give him something to eat and then like a sugar, actually it's a sugar solution. I will not go into details, but we have actually two tests. The one contains 75 milligrams of sugar, sweet fluid, and the other one is 150, but that is used for the pregnant lady. Yep, absolutely, you are correct. So the pregnant lady, this is the test of choice for them. They ask you about the pregnant lady, oral glucose tolerance test is the test of choice. So 2 hour oral glucose tolerance test. After 2 hours, it's 200. This is pathological. That means this patient is not tolerating the glucose normally, which it's a sign of diabetes mellitus. 2 hours after consumption of 75 grams of glucose in the water, the patient glucose level becomes really high. So random plasma glucose, if it was more than 200, this is basically telling you that this patient also have high risk of diabetes. Okay, but for this one, it's not enough to have the high level of sugar. You also have to have an actual symptom. For example, polyuria, polydipsia, and this stuff. Okay, insulin deficiency or severe insulin insensitivity are the cause. So either your pancreas is not producing any insulin, or he's producing insufficient amount of insulin, or he's producing actual insulin, but the insulin is bad, or he is producing the insulin and the insulin is good, but the receptor is bad. Okay? So again, you can get diabetes if your pancreas is not producing insulin. This is actually type 1 diabetes or type 2 diabetes, in which your pancreas does produce the insulin, but it's not enough, or it's dysfunctional, or the receptor is bad. So they write here, first of all, okay, my insulin is bad, so what's up? They write, decreased tissue glucose uptake, because one of the main function for insulin was to put the sugar inside of the cell. So now we will have a less tissue glucose uptake. Okay, so if the cells cannot uptake the glucose, he will stay inside of the circulation. If he is inside of the circulation, that will lead to hyperglycemia. Okay, also such processes will be activated, which also promote to hyperglycemia, like gluconeogenesis and glycogenolysis. Okay, we have so much sugar now. We have so much sugar that it reaches the threshold. How much was the threshold of the kidney for the sugar? It was between 180 until 200, and when he reaches the threshold, we will start to have glucosuria. Okay, so the patient plasma osmolality is going to go up. Why? Because sugar, the glucose, is osmotically active. That increases the plasma osmolality, which make you quite thirsty. It's basically a defense mechanism to dilute the plasma. Okay, to dilute the plasma. Also, a lot of sugar is going to the urine. Again, sugar is osmotically active, which means it's going to draw with it water, and that will lead to osmotic diuresis. So you will be losing not only water, but also electrolyte, sodium and potassium. So you are going to have hypovolemia, that's bad, which can lead to decrease in the effective circulatory volume. Okay, so that leads to circulation failure and decreased tissue perfusion, including which main organ will have less perfusion? The brain, and that can precipitate to coma and death. Okay, so let's speak about also, ischemia of the organs for a long period of time is going to make them go to the anaerobic glycolysis, which make them more serum lactate, anaerobic glycolysis. So more lactate is going to lead to increased anion gap metabolic acidosis, which as a response we will have respiratory alkalosis, which is mediated by hyperventilation or chiasmal respiration, which I will show you in a video in a second. Okay, actually let me do it now, the chiasmal respiration. So chiasmal respiration, chiasmal breathing. So chiasmal respiration is a way in which, like, it's a defense mechanism against the metabolic acidosis. It's basically really quick breathing rhythm. Okay, so but it's deeper. It's much deeper. Okay, so I hope I will be able to see some video of it. Okay, look, this baby has diabetic ketoacidosis. Nothing.
2 years ago, I'm sorry. At 3 years old. Okay, at 3 years old. Okay, so he's 5 now. Okay, and this is this the second?
See, he's breathing rapidly, but also really deeply. It's a compensatory mechanism to lead to respiratory alkalosis. Yeah. How is he having the respiratory alkalosis here? How do you think?
Time he presented with breathing like this, or has he ever?
I've never seen this before.
You've never seen this before. Okay, so this is the first time. So, all right. Well, thank you so much for letting us do this.
Okay, so basically he's kicking all of his CO2 out, right? So that's why he develops the metabolic alkalosis. Okay. So they write here that also, you cannot hear me. Can you hear me? Okay, I got closer to my computer, so hopefully you can hear me better now. Okay, so basically the patient is going to have metabolic alkalosis, and this is due to rapid respiration, which kicks out a lot of CO2, right? So the patient also can have the following: increased proteolysis, which basically is going to destroy his muscles, so less muscle mass and weight loss, obviously. Okay, so you remember some of the protein can go to the gluconeogenesis pathway, which eventually going to make more sugar and going through this pathway or this pathway. Lipolysis, which will increase the amount of free fatty what? Acid. So free fatty acid can becomes ketone body. The ketone bodies can lead to ketogenesis and ketonemia and ketoria. I have a question now. Is this in diabetes mellitus type 1 or type 2, the ketogenesis? I mean the DKA. Let me be more. Yeah. Okay, so if it was a DKA, an actual diabetic ketoacidosis, this is only in type 1, not type 2. In type 2, we have something totally different. Okay, so people who have ketosis will have vomiting, and vomiting will makes you lose electrolyte, which also make you go to this cycle, which eventually will lead to coma and death. Okay, so that's in general why insulin deficiency or insufficiency is going to be bad. Now, types of diabetes. First of all, let's start with this. Children versus adult. Children, do they get type 1 or type 2 diabetes? Children. Okay, who gets DKA? Who gets hyperosmolar hyperketotic state? Hyperosmolar hyperglycemic state. Type 2 diabetes. Who's going to get it after age 40, let's say? Nice. Who's going to have amyloidosis? This is tricky. It's type 2. Type 2 are going to have amyloidosis. Type 1, they will not. I will explain why later. So, the type 1 diabetes mellitus, as I said, it's a problem in the production of the insulin. So, production is bad. So, okay, autoimmune T-cell mediated destruction of the beta cells of the pancreas due to the presence of something called the glutamic acid decarboxylase antibody, which are going to tag the beta cells, and these beta cells, when they are tagged, the T cells will come and lead to their destruction. Okay, so that will help us to kill the B cells. It's not something good, actually, it's really bad. So if the beta cells are dead, we have zero insulin. So do we need insulin for the treatment, or is it enough to give the like oral drugs? Can we give oral drugs? I mean like the metformin, or we must use always insulin in type 1? So the answer that you must always use the insulin. You cannot use the oral anti-glycemic drug. But we need insulin. Okay, so look, you always need the insulin. The oral, you can add them, but the primary treatment is basically is going to be the insulin. Okay, so insulin is the type 1 treatment. Okay, so let's say it was a child and he is having a lot of pain from the injection, and his family is like, please doctor, help us. Can you prescribe him any other medication that help him, or only insulin? You know, insulin is basically you need to be administered like subcutaneously. Only insulin. There is nothing you can do. The only thing you can suggest for them is this insulin pump. I don't know if you know what that is, but there is basically something called an insulin pump. Also, they call it, I think, like a artificial pancreas or something. Yeah, something like this. It's like pain-free. It's going to release the insulin directly. Yeah? Yeah, you can also put, good trick. Yes, nice. So you can put like lidocaine and then, yeah, give him the thing. So, insulin is necessary for a treatment? Absolutely. The age is under 30. We discussed that. Obesity, not really. Why? Because look, these patients basically are having it in a really young age, basically, and it's totally hereditary. It's the antibody attaching to the beta cells, and then the T cells coming and destroying the beta cells, right? So the insulin is going to be low, and they will not have any glucose going inside of the cell, which prevent them from making fat. So they are going to become really, really thin. Genetic predisposition, relatively weak, which mean, yeah. So basically, it's really, if my father, for example, had diabetes mellitus type 1, I have low chance of getting diabetes mellitus type 1. Okay? Here they are speaking about identical twins. So two like patients, twins. So they are similar in everything, right? So they checked, okay, patient number 1 has diabetes, patient number 2 has no diabetes, which means it has zero relationship to, well, basically, did he get it from the father or not? Because if he got it from the father, both of them will have it. But here, 50% of them had it, 50% did not, which means it's another cause that we don't actually know exactly why we develop these antibodies, because the antibodies are the main cause of the problem. So yeah, you have this beta cells, you have the antibody against it, and after that the T cells come and attack it. But why we have the antibodies, we don't know. Okay? So that's actually the problem. Who knows? Maybe it's a virus or something like H. pylori. Actually, fun fact, H. pylori used to be never thought that it's caused by, sorry, the ulcer, they never thought it was caused by the H. pylori. This was only recently, I think like 50 or something years ago. The guy won the Nobel Prize for that. Deserve it. Okay, so it's polygenic, which is the same as saying multifactorial, which means it has a little bit of hereditary stuff, but most likely it's going and plus what? Environmental factors. So environmental factors also play a role. Hereditary and environmental factor. When both of them cause the disease, we call it multifactorial or polygenic. So they have association with some HLA. We have the HLA DR4 and DR5. Sorry, DR4 and 3. I have a question. Which MHC hit it? Come on, tell me. Which MHC is it? MHC type 2. Excellent. Why? Because how many letters? 2 letters. Remember. Okay, let me give you one HLA just to make sure you know what this is all about. So if I give you an HLA A64, it's HLA type 1 because we only count how many letters. If it was AB64, type 2, because 2 letters. We don't care about the numbers, we only care about the letters. So the glucose intolerance is severe because basically they have zero insulin. Insulin sensitivity is high. Why? Because they don't have any insulin, so the receptors become upregulated. Ketoacidosis does occur, and the beta cell number in the islet are going to be decreased because they are destroyed. So we cannot give the sweets, right? Yes, absolutely, you cannot. Well, if you want, you can, but you need to have some insulin nearby. Okay, beta cell number is going to be down because they are going to be destroyed by the T cells after the antibody attaches to them. The serum insulin level is going to be down. What about the C-peptide, guys? What is going to happen to the level of the C-peptide? It's going to be low. No insulin, no C-peptide. Remember, they are released together. The islet are destroyed. So no insulin, no C-peptide. Both of them are produced concomitantly together with each other. If you don't have them, no C-peptide. The classical symptoms of polyuria, polydipsia, and polyphagia can occur. Also, weight loss. All of these symptoms are common. Okay. Finally, the history. Islet leukocyte infiltrate. Yes, so you can have an actual leukocyte, but basically, is it T cells or B cells? What do you think? In the islet. T cells, absolutely correct. Nice. Okay, type 2 diabetes, it's an increased resistance to the insulin or bad insulin. Okay, so progressive pancreatic B cell failure. So the insulin, is it necessary for the treatment? Not always. Okay, it's some, most of the patient, for them it's enough to give like the metformin, sulfonylurea, the oral anti-diabetic medication. But sometimes when these medications don't cut it, you have to add some insulin. So the age is most likely in the older population, and it is associated with obesity. And actually, it's the cause of it. And why? Because obese patients do have insulin, but it's not enough. The genetic predisposition, it's pretty strong. So if the parents are diabetic, there is really high chance the children are diabetic. Again, it's polygenic. Association with the HLA, zero. Nice. Okay, the next one, glucose intolerance is mild to moderate compared to the glucose intolerance in the severe cases. Keep in mind, guys, the guy who discovered the insulin as the treatment won the Nobel Prize. From which animal do we get the like the insulin to give it for the human being? Not now. I mean, when it was first made. Now we do it in another way. Yes, it was from the swine, which is the pig, and the rat. Okay. Okay, but right now we get it from E. coli actually. We make the E. coli work as a factory, keep producing us the insulin without the need of any of these like pig or rat or anything like that. Okay, so the B cell number, it's variable with amyloid deposition. Let me explain why the amyloidosis occur. Basically, you have so much insulin. Yes, insulin will it's dysfunctional. So this dysfunctional insulin is going to convert to a substance called amylin. This amylin is going to deposit in the beta cells and is going to lead to amyloidosis of the beta cells. What is the definition of amyloid? Okay, it's a protein, beta-plated protein that is misfolded, right? Misfolded and deposit inside of the tissue. Okay, if somebody has an amyloidosis of some organ, is there any medication we can give, or there is nothing we can give this patient? There is nothing we can do, absolutely. Okay, so the serum insulin level is increased initially, but eventually it goes down. And why? Because you start having amyloidosis of the beta cells. And the symptoms, like the polyuria, polydipsia, and these stuffs are variable. They can occur, but if they don't occur, don't come after me. So the histology, you are going to see amyloid polypeptide deposits. And I have a question. Which stain do we use to diagnose the amyloidosis case? Excellent. Two of them. The Congo red stain and the Avoli green birefringence. Nice. Okay, guys. So let's take a little break for 10 minutes and I will see you guys in 10 minutes. So, first of all, can you see my screen? Can you see my screen, please? Okay, good. So, hyperglycemic emergencies, we have one for the diabetes mellitus type 1 and for the type 2. So, for the type 1, we have the following. For the type 1, we have DKA, diabetic ketoacidosis, which is basically happens in patients who are non-compliant to their insulin. Which category of patient don't like to listen to the adults and also in the same time have diabetes? Teenagers, yep, they think they are badass. Yep, yep. So teenagers, they think they are badass and they don't want to listen to the adults and they stop taking their insulin because they think that, like, yeah, I don't want to take my insulin, I'm manly. And they have decay. Increased requirement due to increased stress. For example, During infection, surgery, or stuff that are really stressful, we'll have more um, glucose in our circulation because of the basically the cortisol will increase our glucose level, and thus you will require more insulin. Excessive lipolysis and increased ketogenesis from increased fatty acid, free fatty acid, will lead to a lot of ketones body into your circulation, leading to beta hydroxybutyrate and acetoacetate into your circulation. Well, acetoacetate can be released by your lung and it smells like acetone. Where do we find acetone? I mean, like, it smells like what? Acetone. I hope you are thinking about the nail polish. Yes, excellent. So yeah, it's the nail polish. So insulin deficient ketones are present. Good. So guys, whenever you have no insulin, you are going to have ketones body. In the type 2, we do have insulin, so no ketones body. Okay, signs and symptoms. DKA is deadly, so it can lead to delirium and psychosis. Please know the difference between delirium and dementia. Delirium occurs rapidly. Dementia takes a lot of time. Delirium is reversible. Dementia is not. Okay, nice. Delirium, what else? I forgot. Well, these are the main things. Chiasmal respiration, which is a rapid, deep breathing. To kick what out? Why they have chiasmal respiration? Why do you think? To kick the CO2 out, and that will lead basically to a compensatory respiratory alkalosis to compensate for the diabetic ketoacidosis, which is a form of increased anion gap metabolic acidosis. Yeah, so it's a compensatory mechanism. Abdominal pain, nausea and vomiting can occur, and also dehydration. Frothy breath odor due to an exhaled acetone can be, you can smell it. Okay, so in the labs you will see hyperglycemia and increased hydrogen because of the ketones body are actually acidic. Decreased bicarbonate, which is highly indicative of metabolic acidosis, and it will have high anion gap. Why? Because of the ketones body. Yeah, the ketones body lead to high anion gap. Can someone remind me how to calculate the anion gap? So it was sodium minus, come on, minus what? Chloride plus bicarbonate, or minus bicarbonate, okay? So the sodium minus these two. If you forget about it, just what I personally say, it's the positive minus the negatives. So the sodium is positive, the bicarb and the chloride are negative, so the positives are minus the negatives. You get yourself this result. Okay, so let's take a look. Increased urine and the blood ketones level and leukocytosis. So also sometimes you can have increased amount of potassium. Why? Because normally the glucose help it to move inside of the cell. Now no the insulin help it to move inside of the cell. No insulin, it will stay outside. They write normal or increased serum potassium, but depleted intracellular potassium due to transmural shift from decreased insulin and acidosis. Let me explain again. To move potassium inside of the cell, you require some insulin. So if insulin is not here, the amount of potassium inside of the cell will be low, but outside of the cell will be high, right? So this is what they say here. Basically, no insulin, high potassium outside of the cell, low potassium inside of the cell, because no shifting. Okay, osmotic diuresis can occur, which increase the potassium loss in the urine. So overall, the amount of body potassium is going to be depleted, even if you fakely see it as increased inside of the circulation. Okay, which complication can we have? Life-threatening mucormycosis. That was a fungi. Do you remember how this fungi can enter the brain? How can mucormycosis enter the brain? Through what? Which hole? the nose, and then absolutely correct. It's the cribriform blade. The cribriform blade, which is, yes, it's this area in the ethmoid bone. Through it, we can reach the brain. Yep, so it's just right here. Good. So, cerebral edema can also occur in this patient, and cardiac arrhythmia because of the hypokalemia. How came the fungi? How come the fungi? Well, this fungi especially like the ketones body. To be totally fair with you, it's located in a lot of places, even on the bread. I mean, you know, like the bread, actual bread, loaf of bread. But why it does not affect us? The answer, because if our ketones body are normal, that's one thing. And the second thing, that our immune system is perfecto. But a patient with diabetes, his immune system sucks, and they have a lot of ketones body. And as I said, this fungi like to eat ketones body. Okay, cardiac arrhythmia because of the hypokalemia. Because overall, well, they have hyperkalemia, yeah, but inside of the cell it's hypokalemia. Regardless, this electrolyte disturbance can lead to cardiac arrhythmia. Okay, so the second one is hyperosmolar hyperglycemic state. This is type 2 diabetes, not type 1. Profound hyperglycemia lead to an excessive osmotic diuresis, which is a lot of sugar going out in the urine, which will dehydrate the patient and increases the serum osmolality because a lot of free water is getting kicked out. So we call that hyperosmolar hyperglycemic state. It's mostly in old people with diabetes mellitus type 2 and limited ability to drink. Who is old, have type 2 diabetes, and cannot drink? Come on, any idea? Yeah, well, coma is true, but we can give them. I mean, as doctors, if we have somebody with coma, we will always know that he needs to have some fluid, so we will inject him with the fluid. Okay, the answer is somebody who forgets to drink. Who forgets to drink? He's really old and have diabetes mellitus type 1. Absolutely correct. It's an Alzheimer patient. He forgets to drink. Like the Alzheimer patient forgets everything, even to drink. So these are highly likely to get this state, HHS, I'm going to call it. Yep, those geriatric it's highly possible as well. So insulin is present, but the ketones body are absent. Why? Because you have insulin, no ketones body. So they're right. The symptoms and signs are thirst, polyuria, lethargy, and focal neurological deficit, and plus seizures. So the patient is going to have a lot of neurological symptoms, as you can see. The laboratory will show a ridiculous amount of hyperglycemia, even higher than diabetic ketoacidosis. I mean, in the diabetic ketoacidosis, it's going to be between 200 until 350, okay? But here, in the hyperglycemia and HHS, is going to be more than 600. The serum osmolality will be humongous, more than 320, and this is going basically to suck water even from the brain. And normal pH, no acidosis, no ketones body, but again, the serum potassium can be higher because of the insulin insufficiency. But overall, the potassium inside of the cell is going to be low. You are like, but there is insulin. Yes, but it's dysfunctional. It can progress to coma and death if untreated. Well, both of them sucks actually. Both of them can lead to death. Yep. So the next one is how to treat them. Let me ask you this. Should you give first fluid or insulin? The patient has type 1 diabetes mellitus, DKA, and really severe state. Should you give insulin or fluid? The correct answer is the fluid. Why? Because why the patient is dying? Because of the hyperosmolar state, the increased amount of glucose. So you need to dilute it immediately. That's the thing you need to know. Basically, they are in a dehydrated state. That's why they die. In both cases, first thing to give is a fluid. Then you start the patient on insulin. Which type of insulin? The answer is regular insulin. Do not be tricked by choosing rapid-acting insulin. That's wrong. You must choose what? You must choose regular insulin. And also you give the potassium to replete the intracellular stores. The patient level of the potassium inside of the circulation is going to be normal or high, but their total potassium is low, so you must give the potassium. Glucose might be required to prevent a hypoglycemia from insulin therapy. Yes. So even when you give the insulin, make sure that you correct it slowly and not rapidly, not to give the patient hypoglycemia. What is more fatal, hypo or hyperglycemia? Absolutely correct. Hypoglycemia is much more fatal. And I told you yesterday, whatever the cause, give it glucose, right? So, hypoglycemia and diabetes mellitus usually occurs in patients treated with insulin or insulin secretagogue, which is the substance that helps to secrete the insulin, like the sulfonylurea or the glitz. You are like, but here it's written glitinides. Yes, but in medicine, we like to make it easier on ourselves. So the anti-diabetic medication, we just have like one section of them and we call it like that. So we have the GLIPs, we have the glitz. We will see all of them, don't worry. But these ones, we call them the glitz. So yeah, in the setting of high dose treatment or inadequate food intake or exercise. So the patient is going to do what? The patient is going to take the insulin and then go to the exercise. Really bad idea, because during exercises he's burning sugar, so he's having hypoglycemia. Insulin also lead to it, so he's in a bad shape. Also, somebody who does not eat anything and takes his insulin. This is why you need to be careful if the patient does practice fasting. You need to tell him, well, listen, if you fast, it's okay, but you need to know that you should not take your insulin while you are fasting. Just take it at the time you stop your fasting. Okay. So the next one is as follows. Neurogenic autonomic neurogenic autonomic symptoms include, the first one is the diaphoresis, and which is what? Sweating. Yes. And also we have the tachycardia, tremor, anxiety, and hunger. This patient can be really, really hungry. They can eat you. I'm not kidding. They really becomes a little bit crazy. If you see a patient who have hypoglycemia, they will be shaking, okay? They will be sweating. They will be extremely hungry. And what you should do for them, give them the food right away, okay? Don't joke with them, because this literally can kill them, okay? It's not something simple. So what should I feed them? Should you give them like a steak or something? The answer is not really. You need simple carbs. For example, what? Well, honey is possible. Honey is highly possible. Or most likely, if you can give them some juice from like fresh juice, that will be just amazing. Okay? Because it's like just a fructose, simple carbs. It's just perfect. So they may allow perception of decreased glucose, hypoglycemic awareness. So this is important. These signs, the neurological and the autonomic symptoms, are they good or bad? Are they good or bad, these signs? They are super good. I will tell you about that point in a moment. But they are super good signs, these signs. Why? Because they help you to know that, okay, I'm getting hypoglycemic, let me eat right away, right? But if it is not happening, you will get coma right away, which is already too late. You cannot do anything at that state. So the way to differentiate between hypo and hyper. In case of hypo, you will have like this shaking, tachycardia, diaphoresis, anxiety, and I want to eat right away. In case of hyper, you will have polyuria, polydipsia, okay? Polyuria, polydipsia, and here in this case, in the DKA, you are going to have acetone color, okay? Sorry, acetone smell. And in case of the hyperglycemic, hyperosmotic state, you are going to have, again, the thirst, polyuria, polydipsia, all of this stuff, but you might have seizure as well. So the main thing is the hunger. The hunger tremor that, and I want to eat right away. This is hypoglycemia. If I'm just going to the bathroom so many times and I feel drowsy, this is hyperglycemia. So these signs are really good because they allow perception of decreased glucose, hypoglycemia awareness. Do you know any medication that can prevent these signs from occurring? So let me tell you, these signs are beta mediated, beta receptor mediated. So people on beta blocker will not have these symptoms. Because they will not have these symptoms, they are going to develop these symptoms right away and not these symptoms. So what are these symptoms? Neuroglycopenic symptoms, which is the progressive state already. They will have altered mental status, seizure, and death due to insufficient glucose in the CNS. Okay, so is it a good idea to prescribe wide spectrum beta blocker for patients with a really severe diabetes? Not really, it's not a good idea. You need to be careful which type of beta blocker you are prescribing. If you had to prescribe something, prescribe selective beta blocker for these patients, not non-selective. And also, yeah, keep in mind that if you use the wide spectrum, it will hide these symptoms, which will lead to the patient having the severe state right away before feeling any alarm. So the treatment of this disease is simple carbs like glucose tablets or fruit juice. Also, you can give IM glucagon, which is basically the exact opposite of insulin, and IV dextrose, which is sugar, 5% glucose. Okay, good. Done with diabetes. Let's speak about Cushing syndrome. Cushing syndrome and Cushing disease. They are totally different from each other. So the etiology is so much cortisol because of various causes. Can somebody tell me where is cortisol secreted from? Cortisol is not secreted from the pituitary. This is wrong. Cortisol is secreted from another organ. No, it's not the hypothalamus. It's the adrenal gland. So the adrenal gland is the organ that produces the cortisol. So for the adrenal gland to produce the cortisol, the hypothalamus must release the adrenocorticotropic releasing hormone, and then the anterior pituitary produce the adrenocorticotropic hormone, and the adrenocorticotropic hormone is going to affect the zona GFR, zona fasciculata, to secrete the cortisol. Okay, so the zona fasciculata within the adrenal is the organ that produces the cortisol. Okay, more cortisol due to variety of causes. Exogenous cortisol will decrease the ACTH. For example, who takes exogenous corticosteroid? Who do you think? Correct. People who have autoimmune disease or people who have who are using it as an immunosuppressive drug because of transplantation or something. Also, patients who have like some really severe form of autoimmune disease like arthritis, rheumatoid arthritis. Okay, so if you take exogenous corticosteroid, you can have Cushing syndrome. It's the most common cause, and the adrenal gland will be atrophied because they will be non-functional, and the ACTH will be low because no need for it. Primary adrenal adenoma, hyperplasia, or carcinoma. So you have a lot of cortisol, so there is no need for the ACTH. It's going down because the adrenal gland is autonomous. It produces without the help of ACTH. So, but the tumor can occur in one adrenal. So the other adrenal has no need, so it will become atrophied. Yeah? ACTH secreting pituitary tumor, it's Cushing disease. I want you to notice something here. Syndrome is the big term. Anything that increases the cortisol, we call it syndrome, Cushing syndrome. But if the cause is increasing the cortisol by increasing the ACTH from the brain, we call it Cushing disease. So ACTH secreting pituitary adenoma, this is Cushing disease. So we also can have something called paraneoplastic ACTH secretion, for example, from a small cell lung cancer and also bronchiogenic carcinoid. Keep in mind that squamous cell carcinoma of the lung can produce what? Squamous cell carcinoma of the lung can produce, come on. Well, the squamous cell carcinoma of the lung can produce parathyroid hormone related peptide, okay, which can lead to hypercalcemia. So these patients who have ACTH, a lot of ACTH, they are going to have adrenal hyperplasia. Why? Because they are producing so much. Two of them, right and left, both of them will have hyperplasia. Cushing disease, which is like autonomous production from the pituitary, is responsible for the majority of endogenous cases of Cushing syndrome. Yeah, so Cushing disease can lead to Cushing syndrome, but not the opposite actually. But it's not the only cause, obviously. The most common cause is exogenous corticosteroid, but this is exogenous. But if we speak about endogenous causes, Cushing disease is the most common cause. So the finding of somebody with a lot of cortisol include the following: Cushing syndrome, high cortisol inside of the body. These patients are going to be obese, high urinary free cortisol, which is one of the tests we detect the high cortisol inside of the body with. Skin changes like thinning and stria formation. As you can see this reddish fibers here because of like this collagen is here, and we are going to speak a little bit about it actually now. And hypertension as well. This patient, they can lead to enhancement of the catecholamines function, leading to vasoconstriction and thus leading to hypertension. So again, the cortisol, let me just open biochem and show you this, because this is important actually. So as you can see here, the cortisol is like upregulating one enzyme which help to make norepinephrine, which is a vasoconstrictor, and this vasoconstrictor can promote to hypertension. Okay. So the next thing. Okay, immunosuppression by Cushing syndrome can also occur, and also neoplasm, a cause not a finding. Yes, so it's neoplasm can lead to Cushing syndrome, but it's not a symptoms. Growth restriction in children can occur, and high sugar. Why? Because they can lead to insulin resistance, also activation of the gluconeogenesis. Also, it can lead to amenorrhea, which is absence of the menstrual cycle, moon phases, as you can see here, and buffalo hump. I want to show you the buffalo hump. Yep, it's this thing. You can see the buffalo hump on their neck. Okay. So, also they can have osteoporosis, increased weight, truncal obesity, and a lot of hair, hirsutism. The diagnosis can be done as follows. Increased free cortisol on the 24 hours urine analysis. This is the gold standard. But guys, you need to collect the urine of the patient for 24 hours. Do you think this testing is convenient? Not really. So we actually don't use it that often. Yeah, so you know, like you need to collect all of his urine for the whole day and check all of it. It's highly inconvenient. So instead we can do late night salivary cortisol test, which is actually, yeah, one of the most, we like to do this one. And no suppression with an overnight low dose dexamethasone test. So this low dose high dose thing is really important, You must be able to differentiate, okay, how does this test work? What should I do first? What should I do second? First of all, in Cushing syndrome, you need to confirm that you truly have hypercortisolism. You need to confirm that you have a high amount of cortisol. To do that, this is the first step, is by checking the urine free cortisol for 24 hours. This is the first way. Or checking the late night salivary cortisol. Or finally, trying a low dose dexamethasone suppression test. And if it does not suppress, that's a positive sign of increased cortisol. Then you do measure the ACTH. Is it high or low? If it's low, that means that whatever causing the hypercortisolism, it's not endogenous, it's from the outside of the body. So we call it ACTH independent Cushing syndrome. So they say exogenous glycocorticoid or adrenal tumor. Why adrenal tumor? Because adrenal tumor secreting cortisol. What is going to happen to the ACTH if the adrenal is producing cortisol autonomously? It's going to go down. Absolutely, it's going to go down. So yeah, you need to consider CT to confirm an adrenal tumor. Okay, let's say the ACTH is high. That's telling you it's either from the brain as a Cushing disease, or it is from an exogenous location, like for example in the lung. Yes? So how to confirm and how to find it? So ACTH will be elevated. It's an ACTH dependent Cushing syndrome. So there is two ways to find it. The first one is a high dose dexamethasone suppression test. Be careful. Initially we used the low dose. Now we use the high dose. So the high dose is going to be something like this. It's either you have no suppression or some suppression. If you do have suppression, congratulations, you have Cushing disease. If you don't have suppression, it's cancer. If you don't have suppression to the high dose, this is cancer. This is an ectopic ACTH secretion, which is due to a cancer. Should check the chest, abdomen, and pelvis for the site of that cancer that is producing ACTH. If you do suppress it, it's not cancer, it's Cushing disease, which means it's from the brain. So you need to do an MRI of the pituitary. Okay, so this is one way of checking it. The other way is with the corticotropin releasing hormone, which is produced from where? Where is corticotropin releasing hormone produced? The hypothalamus. And no, corticotropin releasing hormone is produced in the hypothalamus. Okay, hypothalamus produce corticotropin releasing hormone, and then the pituitary is going to produce ACTH. Okay. And then the adrenal gland only produces cortisol. That's it. Cortisol. Also, it can produce like mineralocorticosteroid like aldosterone and sex hormone, but cortisol, not CRH, not ACTH. Okay, so the corticotropin releasing hormone stimulation testing will increase the ACTH and cortisol if it was Cushing disease. Done. But if it was a cancer don't really care. So no increase in the ACTH and cortisol, that tells you that it's a cancer. So basically irresponsive. So notice something. The CRH stimulation test, no response. So this is a cancer, ectopic secretion, so you need to do the CT. High dose dexamethasone suppression test, no response. That is also, this one, no response, no suppression. So it's an ectopic, again, cancer, which means you need to check the whole thing. So this is the difference between the two. Okay, so you have discovered the patient with the serious disease. What you should do if he has like an adrenal tumor, hypersecreting this. What thing you can do for the patient with Cushing syndrome due to two tumors from his kidney? Tumors of the adrenal. So basically you will remove the adrenals. Okay, yeah, cut the adrenal, that's it. So just remove the adrenal. Okay, both of them have the cancer, so should I remove one or remove both of them? It's cancer, so remove both. So the next pathology we are going to speak about is related of removing the adrenals. It's called Nelson syndrome. If just think about it. If I remove both adrenals, what is going to happen to the ACTH? Absolutely correct. It's going to be up. What secretes the ACTH? No, it's not hypothalamus. I said the hypothalamus produces the corticotropin releasing hormone. The pituitary produces ACTH and the adrenal produces cortisol. Again, corticotropin releasing hormone, I will write it. So corticotropin releasing hormone produced by the hypothalamus. Okay. So if I speak about the ACTH, this is produced by the pituitary. But if we speak about the cortisol himself, it's going to be produced by the adrenal from zona GFR. It's the second one, so fasciculata, right? Okay, so enlargement of a pre-existing ACTH secreting pituitary adenoma in case of Nelson syndrome. So what is Nelson syndrome? Basically, that patient that you removed both of his adrenals now is going to develop hypertrophy and hyperplasia of his pituitary. Enlargement of a pre-existing ACTH secreting pituitary adenoma after a bilateral adrenalectomy for refractory Cushing disease. Okay, so there will be an increase of the ACTH. There is going to be hyperpigmentation of them, and that, yeah, more ACTH. Remember, the ACTH comes from something called preobio melanocortin, which means you will have more melanin stimulating hormone. More melanin stimulating hormone means more melanin. That will lead to hyperpigmentation. Also, mass effect such as headache and bitemporal hemanopsia due to the compression of what? What are we compressing? Leading to bitemporal hemanopsia. Absolutely, chiasma optica, the optic chiasm. So basically, the pituitary gland is going to compress, this is the pituitary, is going to compress the chiasma optica. Even better. This is the chiasma optica, which is the connection of the two. Yes, okay, that's what I was looking for. You can see the chiasma optica. This is the pituitary gland, and if it enlarges, it can just compress it, and that is going to lead to bitemporal hemanopsia. Okay, so the treatment, a transsphenoidal resection of the pituitary gland through the nose, and the postoperative pituitary irradiation for residual tumor. So yeah, if there is something left in there, you can do irradiation by, nuclear irradiation to keep the tumor in its place and not for the tumor to move to another location. Okay guys, so let's take 10 minutes break and I will see you guys in 10 minutes. Hello guys, welcome back. So now we are going to speak about adrenal insufficiency. So regarding adrenal insufficiency, it's the adrenal gland not working for some reason. So let's take a look. Why is that? What is happening exactly? So adrenal insufficiency, inability of the adrenal gland to generate enough glycocorticosteroid or mineralocorticosteroid for the body needs. So can you just remind me where exactly the mineralocorticosteroid inside of the adrenal secreted? Zona glomerulosa, absolutely correct. Just remember, it's GFR. The deeper you go, the sweeter it gets. The G for glomerulosa, so that's mineralocorticosteroid. Fasciculata, this is glycocorticosteroid. Reticularis, this is sex hormones. Okay. So now we have the following. They're right. The adrenal insufficiency can be either acute or chronic. Symptoms include weakness, fatigue, or orthostatic hypotension. Orthostatic hypotension means the patient, when he's basically laying down, his blood pressure will be okay. But when he stands up suddenly, he's going to collapse. This is orthostatic hypotension. Also, the patient will have muscle aches and weight loss. Why? Because he's losing a lot of minerals. Well, mineralocorticosteroid, one of their function was to reabsorb the sodium. In case of adrenal insufficiency, there is no sodium reabsorption, which is going basically to lead to hypovolemia and basically shock and weight loss. GIT disturbances and sugar and salt gravy because we are losing both. Treatment is by giving the glycocorticosteroid plus or minus the mineralocorticosteroid replacement. Guys, to be totally fair with you, patients with adrenal insufficiency are a really bad patient because it's difficult to treat. It's difficult to treat these patients. A primary and secondary one, you might be able to treat them, but if you have an acute adrenal insufficiency that happens suddenly, this will be mostly in the ICU and they will die within days. Even with the proper treatment, they die. They like to die. I don't know why, but people with actually we know why. I will tell you why. But acute adrenal insufficiency have super high mortality rate. The first two, however, much lower mortality rate because we can deal with them much more younger. So the primary adrenal insufficiency, decrease of the gland function, which will lead to low cortisol and low aldosterone, which basically going to lead to hypotension, a hyponatremic volume contraction. Okay, so we'll have a volume contraction and basically decrease in the effective circulatory volume inside of the body. Also, we can have hyperkalemia. Why? Because basically aldosterone is not working. So one of the function of aldosterone was to do what with the potassium? Was it to keep it or to kick it out? Mineralocorticosteroid, aldosterone. No, what do you write? So somebody's saying that yes, keep the sodium. It used to keep the sodium and kick out the potassium. So in this case, mineralocorticosteroid are low, so that will lead to high amount of potassium. Also, metabolic acidosis can occur because remember, guys, anytime you have hyperkalemia or high potassium, your hydrogen is also going to go up. This is metabolic acidosis. Okay, so the adrenal is not working. It's not working. So what is going to happen to the pituitary gland if the adrenal is not working? Yep, so the pituitary gland is going to start working harder, which means producing more adrenocorticotropic hormone, right? So more adrenocorticotropic hormone is going to be produced with what? One other hormone, his friend from the same father. What was the name of his father? Yep, the other also corticotropin releasing hormone will be higher, and also most importantly the MSH is going to be higher, which means this patient will develop hyperpigmentation of their skin and mucosa membrane, as you can see here. Can you see the black? Okay. Increased melanin synthesis due to increased MSH, which is a byproduct of a pro-opio-melanocortin cleavage, which is the father of all of these hormones. Primary pigments the skin and the mucosa. So let's take a look at it. The prototypical example on it, something called Addison disease. So let's take a look at Addison disease. Yep, can you see the hyperpigmentation of these patients? Yeah, it's in their hands and their mucosa membrane. Yep. Yeah, black. By the way, guys, those who have a cat, and you look at the cat and you see black spots in the mouth, what is this? I'm not a vet, but you must know this for medicine. What do you think this is caused by? It's most likely caused by an immune dysfunction, and most importantly, it's caused by toxoplasmosis. So, if your cat has this, don't keep it with a pregnant lady, okay? Because this is a sign of toxoplasmosis. Okay, next. Addison disease. It's a chronic primary adrenal insufficiency caused by an adrenal atrophy or destruction. So most common cause in the developed world, like US, Japan, it's autoimmune adrenalitis. In the developing world, it's going to be tuberculosis. Okay, so secondary and tertiary adrenal insufficiency, it's a decrease pituitary ACTH secretion. This is secondary, or a decrease in the hypothalamic corticotropin releasing hormone secretion. We consider this one to be tertiary. So there will be no hyperkalemia. So yeah, aldosterone synthesis preserved due to functioning adrenal gland and an intact RAS system. So this patient, they already have like basically low amount of ACTH. Yes, low amount of ACTH means that they will not have hyperpigmentation, right? So that's the problem. The ACTH is decreased from the brain, or in case of tertiary, it's the hypothalamus. So that means no hyperpigmentation. This is a really important thing. So no hyperkalemia as well, because aldosterone synthesis is mediated by the RAS system, not by the hypothalamic pituitary adrenal axis, right? Not by the HPA. It's mediated by the RAS. So the patient with secondary and tertiary adrenal insufficiency will not have hyperpigmentation. Secondary adrenal insufficiency is due to pituitary pathologies. Tertiary adrenal insufficiency is most commonly due to an abrupt cessation of chronic steroid therapy, which is going to lead to during cortisol therapy. Let's say that I'm taking chronically cortisol. Tell me, please, what do you think will happen to me if I chronically use cortisol? I mean, what is going to happen to my corticotropin releasing hormone and to my ACTH? If I chronically took cortisol, what is going to happen to my corticotropin releasing hormone and to my ACTH? Okay, so both of them are going to go down. That's correct. Okay, so what is going to happen to the size of my adrenal gland if I always inject myself with these steroids? No, they are going to atrophy, become so small, because there is no need for them to work. I'm getting the drug exogenously, so they will become super small, right? Okay, so are they functional anymore when they are small? Not really, they are not. So if I suddenly stop taking the steroid, will I have any endogenous reduction of the steroid? No, that's adrenal insufficiency due to sudden cessation of the chronic steroid therapy. Okay, so acute adrenal insufficiency, which is the one that kills the patient most of the time, also known as adrenal or Addisonian crisis, adrenal crisis, often precipitated by an acute stressor that increased the steroid requirement, for example, infection or surgery or a pregnancy. In patients with a pre-existing adrenal insufficiency or an nonsteroid therapy, it may present with an acute abdominal pain, nausea, vomiting, altered mental status because of the electrolyte disturbances, and the most important thing is this guy, shock. So they will have a massive vasodilatation in their body. Why? Because aldosterone is low. That means the whole RAS system is going to be messed up. And basically, they most of the time die from shock. And the most important, actually, this is not that common, but it occurs, but it's really important for the USMLE, the Waterhouse-Friderish syndrome. It's a bilateral adrenal hemorrhage that happens because of meningococcemia due to Neisseria meningitis. It's most commonly going to occur in a young man, maybe in 18 to 22, that is in college dormitory, okay? And remember, the treatment of Neisseria meningitis was ceftriaxone. Close contact should get what? Which medication should you give? The close contact. Rifampin, absolutely correct. Okay, so it may present with an acute adrenal insufficiency, which means hyponatremia, hyperkalemia, metabolic acidosis. They will have fever, and also, this is super important, the petechia. And they can have also sepsis because of the bacteria. Waterhouse-Friderish syndrome is really tragic, and a lot of patients die from it. If you watch the news from every other week, they write about a college student who suddenly died in the dormitory. Yeah, because of shock. What he died from? Most likely this guy. So keep in mind, most common patient to get it is a young man who are in either the military or the dormitory. Okay, so let's take a look. They write how to check for the adrenal insufficiency. You need to check morning cortisol or ACTH stimulation test. Okay, if the morning cortisol was low or the ACTH stimulation test have low peak, which means it's like it's irresponsive, no response to it, you start suspecting, you already know that you have adrenal insufficiency, you just need to know what is the cause, right? So you check the serum ACTH. If it was high, it's the adrenal dysfunctional. But why? Because this is low, because the adrenal is not functioning. So as a feedback mechanism, the ACTH is going to be high. But if the ACTH was low, that means basically that it could be secondary or tertiary, because basically it's not producing the ACTH. Thus, the adrenal gland becomes with no stimulation, so it just becomes smaller. Okay, nice. Let me just take a look. Okay, let's just measure one thing. So 1, 2, 3, 4, 5, 6. Nice. 1, 2. Okay, good. Let's do this page. Hyperaldosteronism. Hyperaldosteronism, increased secretion of aldosterone from the adrenal gland. A clinical feature include, okay, more aldosterone, more reabsorption of the sodium, hypertension. But here is the trick. They will have low potassium. This is right. And metabolic alkalosis. This is right. We agree. No problem with that. Why? Because of the aldosterone. Because of the contraction, volume contraction. So all of this makes sense. But what messes up everybody's brain is the sodium level. The patient with hyperaldosteronism, primary hyperaldosteronism, can you tell me please, what will happen to their sodium level? I mean, they reabsorbing more sodium. So what will happen to their sodium level? This is the trick. So they reabsorb, they have more aldosterone or aldo. So that will lead to more sodium. More sodium, more water. More water, more volume in the body. More volume, more stretching of the heart chamber. Yeah? More stretching, more secretion of A and B and B and B. More stretching of the more A and B, more B and B, more natriuresis. More natriuresis means lower sodium. Wait a second. So we have high sodium here, low sodium here. So the sum of the action will be normal sodium. Normal sodium. How do we call the whole process? We call this process the aldosterone escape mechanism. Aldosterone escape mechanism. Please know about this process. High aldosterone, high sodium, more water lead to more volume lead to stretching of the walls of the ventricle, more secretion of A and B and B and B, more natriuresis, which means less sodium, because natriuresis is like excretion of the sodium with the urine, and that is going to lead to normal sodium, because this high here, this is low here. Okay, I hope it makes sense. This is the aldosterone escape mechanism. Okay, let's take a look. So they write, primary hyperaldosteronism does not cause edema. Why? Because of the aldosterone escape mechanism. Basically, the sodium will be normal, which will allow for normal regulation of the sodium and inside of the vessels, and that will mediate normal regulation of the water inside of the body. However, certain secondary causes of hyperaldosteronism, like heart failure. Well, wait a second. Why heart failure will lead to hyperaldosteronism? Heart failure means less cardiac output. Less cardiac output, less renal perfusion. Less renal perfusion, more renin. More renin, more RAS system activation. RAS, yes. The last thing in RAS is aldosterone, hyperaldosteronism. That's how heart failure can lead to hyperaldosteronism. Okay, it lead to an impairment of the aldosterone escape mechanism, which is leading to worsening of the edema. Yep. Okay, so let's speak about the primary and secondary hyperaldosteronism. The primary one is also known as the Cone syndrome. It's seen in patients with bilateral adrenal hyperplasia or adenoma. It's Cone syndrome. So they will have high aldosterone and low renin. This is important because it's a primary. So the adrenal gland, the zona glomerulosa, is hypersecreting. So that leads to a treatment-resistant hypertension. For example, you have a patient, they give you in the vignette a patient, they give him thiazide, furosemide, beta blocker, and so many other drugs, and it's not working. How come? It is a treatment-resistant hypertension. It's a secondary hypertension, which means the cause is not like it's not this essential hypertension. So the causes include primary hyperaldosteronism, also renal artery stenosis could be, right? So secondary hyperaldosteronism seen in patient with renovascular hypertension. Yeah, renovascular hypertension, it's basically another way of telling you renal artery stenosis. So in renal artery stenosis, as I said before, the patient is going to have less perfusion to the kidney, which promote more renin, and more renin is going to activate the RAS system. RAS system will lead to hyperaldosteronism. That is secondary. Juxtaglomerular cell tumor. Remember, the juxtaglomerular cell used to produce renin. So these are a renin-producing tumor, which will activate the RAS system and lead to more aldosterone. The next thing is edema. So patients who are in a edematous state also can have such thing, such as cirrhosis, heart failure, or nephrotic syndrome. Why? Third spacing. We call any type of edema can lead to something called third spacing. Third spacing means decrease in the circulatory volume. If you have a decrease in the circulatory volume, what is going to happen to the renal perfusion? What do you think? Less circulatory volume, renal perfusion is going to go down. When it goes down, what happens to the renin? Up. When the renin is up, what happens to the RAS system? Activated. Absolutely, right. Good. So the next thing is neuroendocrine tumor. Neuroendocrine tumor, it's a heterogeneous group of neoplasm originating from endocrine cells, which have a trait similar to nerve cells and hormone-producing cells. So these guys are going to have these tumors that are secreting tumors. And you will see what I mean by secreting tumors. So most neoplasm occurs in the GI tract, like carcinoid, gastrinoma, or the pancreas, like insulinoma or glauconoma, or the lung, like small cell lung cancer, or the thyroid, like medullary carcinoma, or the adrenal, like pheochromocytoma. So let's take a look. Carcinoid, serotonin. Gastrinoma, gastrin. Insulinoma, insulin. Glauconoma, glucagon. Small cell lung cancer, ACTH. Medullary carcinoma, that is going to produce calcitonin. And pheochromocytoma produces catecholamines. As you can see, all of these tumors are producing, okay? All of the neuroendocrine tumors basically produce stuff. Neuroendocrine cells, such as the pancreatic beta cells and the enterochromaffin cells, which normally produce histamine, share a common biological function through an amine precursor, okay? An amine precursor uptake of decarboxylase, despite different in the embryological origin. What do they even mean by that? Well, basically, the biochemical process to create the hormone require a decarboxylation reaction, which we are going to speak about in biochemistry, the metabolism chapter. And it helps to produce the hormones required for the synthesis of insulin and also the histamine. So regardless of the difference of the anatomical origin between the two, they have something similar to each other, which are the markers, okay? Despite differences in the embryological origin, anatomical site, and secretory products, we have some amine precursor that you can share them as a marker with each other. For example, small cell lung cancer and carcinoid, both of them have all of these. For example, they can have chromogranin positive for both of them, a neuron specific amylase for both of them, or all of them actually, synaptophysin for all of them, and you stop here. So these are the generalized type of markers which can occur in all of the neuroendocrine tumors. Okay, the serotonin can be in the carcinoid, histamine in the enterochromaffin cell, and the calcitonin is going to be what it is, the medullary carcinoma. So the treatment you need to do, removal of the tumor and somatostatin analog like octreotide, right? Remember, when somatostatin comes, everybody shuts down, right? So all of these are secretory, and when you give the somatostatin, he will inhibit the secretion of all of them. The last thing is neuroblastoma. Is the most common tumor of the adrenal medulla in children. Okay, tumor of the medulla of the adrenal is mostly pheochromocytoma, but that's adult. Now we are speaking about children, so that is going to be neuroblastoma. So neuroblastoma is most common in children, especially under 4 years old. It comes from neuronal crust cells. Any idea what is the marker of neuronal crust cells, guys? I told you about it before. There was a marker for the neuronal crust cells. Nice, it's the S100 marker, that's correct. It occurs anywhere along the sympathetic chain. What is the sympathetic chain? Well, they don't put it here, but I will show you. Organ of Zucker-Candle. So there is something called the organ of Zucker-Candle. You're like, what? Yeah, there is something called organ of Zucker-Candle, which is like basically it's related to the sympathetic ganglia, which are all over like around the vertebra basically. So let me just show you this, and then I need to show you this. Oh yeah, this is organ of Zucker-Candle, which also can have pheochromocytoma in it. So yeah, so it can be either in the paraganglionic cells, or it can be an actual pheochromocytoma. Okay, so it originated from neuronal crust cells, occurs along the sympathetic chain. Most common presentation is a big abdomen, okay? And it will be firm. The most important thing that the mass in his abdomen can cross the midline. Why this is important? Because Wilms tumor, which is a benign tumor we spoke about in the kidney, cannot cross the midline. So neuroblastoma, cross the midline. Wilms tumor cannot cross the midline. If you forget which one is what, neuroblastoma is a longer name, so it can cross the midline. So, okay, versus Wilms tumor, which is smooth and unilateral. Less likely to develop hypertension than pheochromocytoma. So, neuroblastoma is normotensive. The most important thing is the paraneoplastic syndrome lead to something called opsoclonus and myoclonus syndrome. Basically, they will have this dancing movement. Dancing movement of their hands, their eyes and feet. So let's take a look at that.
Come get the cups. Come on. Oh. Good job.
So this is the dancing feet. Let's take a look at the dancing guys. Can you see the vibration in her eye? It's like, yes, can you see? Yep, that's thing. That's the dancing guy. And somebody really smart just remembered about the raccoon eyes. The raccoon eyes, we can see them in the basal fracture of the cranium and also in the neuroblastoma. That was a rare cause of the paraneoplastic syndrome. So yeah, when you see that also in a child without a trauma, think neuroblastoma. Okay, this is actually really impressive that somebody thought about this. I highly say congratulations, you remember this one. Okay, see this guy can be either a fracture. See what they write? It's either yeah, neuroblastoma because of metastasis to the skull and destruction of it. Good job. Okay, so this patient will have increase of the HVA, which was hemino-mandelic acid and vinyl-mandelic acid, which are basically catecholamines metabolite, and in the urine. You check them in the urine. One of the things we do check for is histology, and you can see something called homerite rosettes, which have like a lumen in the middle and some cells around the lumen, which is basically known as homerite rosettes. So neuroblast surrounding a central lumen, this is a homerite rosette. It's characteristic of neuroblastoma and medulloblastoma. So one of the like markers are bombesin and NSE, which is NSE, I forgot it. Damn it. Just a second. Yes, neuron-specific annulase. It's associated with an amplification of a transcription factor called NMEC. Remember, we had the NMEC, which is the neuroblastoma transcription factor. Okay, guys. So we have 1, 2, 3, 4, 5, 6, 7. These will do tomorrow. No, not tomorrow. I think tomorrow is a break. I'm not sure. I have to check the schedule, and that will be it. I mean, after that, like the next class, we will be done with endocrinology. It will be our last, class in endocrinology, and the next system, I believe, it's going to be the rest of cellular, and after that, we are going to do pharmacology. So see you guys next class. Bye bye, everybody. You are welcome.